to do a couple of slides, but there's in the slide deck that we'll share is a suite of tools to promote, because I know LBN are pushing out to lots of places to say, go and get your flu, go and get your COVID. So hopefully it's the right time to be pushing it for everyone. Hi, Rima.
Afternoon.
Afternoon.
How are you?
Yeah, good, thanks. Busy. I think we're all really busy, aren't we?
Everybody is.
Leading up to winter as well. It's just really ramping up in surgeries as well.
It's definitely got that momentum's on full tilt.
Sure.
I think if we wait a few more minutes, then we can start, because I know we've got a busy agenda.
I'll pop it in the chat, Danielle.
Thanks, Karen.
In fairness, it does get finalised quite late, because we often have pieces that arrive that are important to cover, don't we? And need to drop them in, whatever.
Yeah, and then sometimes people are unavailable because of all of the way that we all work.
Yeah, it does change a little bit.
And just in addition, something to just add with regards to the agenda. So the Q&A session with Dr. Vade, just after that, we can hear from LMC. And if Jack has got anything to add as well, that would be great at that time. Okay, good. I think we can start. Just to remind everybody, this meeting is recorded. If you have any questions, please put them in the chat bar or raise your hand. And if I can ask you to mute if you're not speaking, please. So we've got a really good agenda today. I'm going to do my very best to try and keep to time. The first item is Karen, that's just going to be discussing a few things. And please do come to our AGM. I'm hoping that Karen will be talking a bit about that as well. Yes, over to you.
Thank you, Maggie. If we just move straight in. Yes, colleagues, the annual general meeting for Newham Health Collaborative is Thursday of next week. GPs, PCN colleagues, and colleagues, managers in primary care, you are very welcome to attend. It's an opportunity for you to hold us to account, make sure that what we're delivering matches your expectations, and help us plan the future in terms of how NHC goes forward. If you could let Maggie know, you can see her email address on the slide, just because we will have a light supper around 7 o'clock, and obviously we want to cater for as many people as are going to arrive. And just to say, logistics, parking, we've made some arrangements in Westfield Shopping Centre. If you liaise with Maggie, she can make sure that that's all sorted with you. Okay, if we just move on, I wasn't going to spend a long time on the slides that are in this pack, but I wanted them all to be included because I wanted colleagues to have access to them. LBN and the wider London local authorities are pushing out hard on vaccinations at the moment. They've launched a toolkit. You should have received it. We can send it. We will be sending it to you as part of this suite. Fundamentally, there's concerns, if we just move on, Maggie, that the vaccination coverage is falling and it's not strong enough, and particularly lower uptake in terms of some of the minority groups and vulnerable groups. So the kit has been designed specifically with those cohorts around and those cohorts in mind, and you'll see in the suite of resources there's a particular focus around communities that you can see identified there. If we just quickly move on, you'll see why they focused on those. And one of the key messages of learning in terms of uptake is that people connect much better with people. So it's really helpful if local GPs, local imams, local leaders are promoting uptake of immunisation. So if possible, get someone in the practice just to do a really short video, say why it's important, and post it up on social media. We will help promote those on across the borough as well. So the kit is designed just to give you a simple script. I know not everyone's comfortable with doing these things, and suggest a couple of things you might want to do. So in that toolkit, please just have a quick look through, and please, if you can, get involved and do that. So I'm just going to stop there, Maggie. The slides are more comprehensive. The only other notice I've got is colleagues may also be aware that NHC is promoting a health check service for people in workplaces. So in conjunction with London Borough of Newham, we've now got the opportunity to take health checks into Newham-based workplaces, and they're available to everyone. Doesn't matter, you don't have to be within the age cohort that our current health check service delivers. You just have to be working in the borough, and so that service is rolling out, and we will be reaching out obviously to the big employers first. But if you have thoughts, or if you think there's employments where there's lots of people that would be good to get that opportunity, just let us know. Come through to myself or Asma Karim, and we will try and make sure that we reach out to those workplaces. Thank you, Nadeem. Yes, it's 25 to 84 is the age cohort in terms of the workplace health checks. That's me, Alpana.
Great. Thanks, Karen. So next we've got Dr. Rima, who's going to be discussing any issues you have. So please feel free to speak up. Rima, if you've got anything that you wish to discuss, and then you can take questions after.
That's perfect. Thank you very much. Nice to see you all, and I'm glad it's Friday afternoon. I'm sure we're all really busy in practices. So yeah, nice to see you. I didn't make the last forum, so good to catch up with you all. I had two things that I just wanted to mention today, and then happy to take on any questions. The first thing is around the clinical leadership consultation. I gave an update a couple of months ago. We were kind of in the middle of that consultation period. As you may have recalled, we had to make a 30% reduction in our clinical lead budget in Newham. We're almost to the end. It did get delayed, and the reason was because there were some appeals from particularly around kind of the planned care roles. However, they're sort of towards the end now. HR are sort of finalising all of that, so we're almost to the end. We did go out to advert for two roles. That was a CVD and cancer lead role, and we've got some applicants, which is really, really great. So we're going to be going out to interviews in the next 2 to 3 weeks, and hopefully we can get those two roles in place. I'm definitely recognise there's a significant gap in those two areas in particular. So I think, you know, it'd be really good we can get people in those roles and you know, starting to work on some of those priority areas. The other role is then going to be planned care. So some of the feedback I'd got during the consultation period in Newham was that we didn't have a planned care lead in the borough. And so as part of kind of the negotiating around the consultation, I really wanted to make sure that we can have representation for Newham. So we will be advertising, going out to advert after the consultation is completely finished for one session of a planned care role. It will be someone from Newham. However, the role will be more kind of looking at nail priorities around planned care. So it gives an opportunity for people to kind of work outside Newham, work with other clinical leads from other boroughs. So it's a really exciting role. Once we get the sign off that we can go out, and then we'll be going out to adverts. So I just want people to kind of keep an eye on their emails. If they're interested in that role, then please email me directly. I know I had some in previous the CVD and cancer role people asking me. So please do email me directly. I'm more than happy to kind of give you some more information about that. The next point I wanted to mention was around the primary secondary care interface meetings that have been held mainly face-to-face at Newham Hospital. We've had 2 or 3 now starting from last year, so usually quarterly. And I just wanted to give an update on what's kind of been discussed in those meetings. There were 4 particular areas that we were asked to look at, mainly from a primary care perspective. That was around the hospital making sure they're generating fit notes, making sure that consultants are doing consultant to consultant referrals. So that's onward referrals that should not be coming back to primary care. The other one was looking at the quality of discharge summaries and clinical letters. And the last one was around call and recall. So if specialities are ordering tests, they should be having specific kind of time allocated to be looking at the results and not asking GPs to do that. Now you can imagine this is a massive piece of work to kind of get on with. We have made some progress. I think not as much progress as we wanted. I think Barts Health are really struggling, particularly around the IT side of a lot of things. So with fit notes, they haven't got the electronic IT system to be able to generate them electronically. However, word is going around to making sure that they've got the paper copies in wards and also in clinics. In terms of discharge summaries, again, there seems to be a complexity in the IT in generating templates for standardizing the outpatient letters. However, what we've tried to agree through in the meantime is making sure that the consultants all set an example of how, you know, in terms of an action box. So that's particularly, you know, for GPs to action or for the patient to action, and more importantly, what they've organised and what they've done. So we're not continuously kind of chasing out. So that's also being fed back to all the teams in the hospital to try and get into some sort of standardisation around that. In terms of the onward referrals, you know, it's been great that people have sent me examples of where, you know, that hasn't been done, because I'm able to then feed that back, and that is a tangible example. You know, they can't hide away from when it's an example, and they're going back to those clinicians who are generating that work. So again, you know, this is a long piece of work, but it's happening. There are some differences, but please do continue to send me examples, because this is how we can keep feeding back and making sure that message is being sent across. And that's it from me. Those are the two main kind of items I wanted to talk about. Happy to take questions. I can see Laura's hand gone up. Laura.
Hi, Rima. I'm not sure if it's for you or maybe NHC, but we've got really quite busy in general practice over the past couple of weeks. I'm sure everyone has, in terms of ill kids. Is there going to be any hub or place where we can refer like there was last year?
Shall I
Karen,
pick it
do you
up,
want to come in?
Rima?
Yeah,
Thanks,
yeah.
Karen.
Yeah, Laura, we've been asked to progress planning, but we haven't had confirmation of resource yet. So yes,
Okay.
an ARI hub. We're in the process of planning an ARI service. I'm hoping we'll be able to roll it out from November, because last year it was only December, January, February.
Okay.
So it'd be good to get it up and running quicker. But I'm waiting on confirmation from commissioners that resource is available.
Great. Thank you very much.
As soon as we get that, obviously we'll, I presume NHC will send out all the information as soon as possible. Perfect. Any other questions, comments on anything that I've spoken about as well? Hi, Rana.
Hi, Rima. Hi, everyone. Nice to see you all. So just a couple of things for me. So one, it's really good to hear that you are getting the roles for cancer and CVD. I know everyone's mentioned about the Omnis and like is it Omnis on the
Yes,
quality,
healthcare.
yeah, and just the quality of, I'm sure you know. But again,
Yeah.
I don't know we don't know who to pick it up with. If there was, I'm assuming that would be a CVD lead would be an ideal person to kind of be able to take that forward. So I can park that my Omnis complaint maybe.
So Rana, can I just I'll pause you there, just question.
Yeah.
Is it particularly around cardiology diagnostics, or was it generally, because I'm hearing sort of different things. Obviously they do the cardiology diagnostics, but they're also doing ultrasounds and MRI scans and things like that. If there's anything particular, so because I'm be part of the planned care board, which is part of also diagnostics within NEL. So if there's anything specific with Omnis, can you please also let me know directly, because it'll take a little bit of time for CVD lead to come into role.
Okay, brilliant. I will do. Actually, I only use Omnis for the cardiology bit, but I know other people use it for different things.
Yeah.
And the other couple of things, just to highlight, is that with the clinical leads, I know we didn't have one for homelessness anyway when it was advertised, and now obviously that's not even in the equation. I'm just mindful about vulnerable groups, and I know I've been kind of, and Karen knows, I've been kind of involved in this, just thinking about patient registrations, because in Newham there's a huge amount of patients who would assume would know the system and know to be registered with the GP, but are not. So that even though we're all kind of what's that called, safe surgeries from the signed up to that. So I don't know, like who is there somebody who could take that forward, or I don't know. I'm just flagging it again for you all how to kind of not forget about those vulnerable groups.
Yeah, no, it's a really good point, Imran, and this is where we recognise gaps where we just don't have clinical leads. But I know that the council with NHC are doing kind of a lot of work around this in terms of kind of projects and pilot work. So, Karen, did you want to come in at that point?
Yes, sorry, and our partner might be about to say the same. Apologies. So we've been doing outreach to the food banks and to settings where we know communities are less registered. As you know, Imrana, we've done some work on unregistered patients, mainly children's cohorts, and we've flagged that through to commissioners. Wherever possible, we encourage people to sign up with a practice. At the moment, there's no additional resource to do promotional work for pushing out to get more of the unregistered with practices, but we're in dialogue with commissioners, and it's a constant push from us that something needs to be done to support that activity.
That's great. Thank you, Karen. I know you put your hand down. Was there anything you wanted to?
No, I was going to echo what, but basically Karen mentioned what I was already going to say. But I think that, I think we opportunistically, because sometimes a lot of the time patients come in and they ask, can I register? Do I need to have proof? I don't have any papers, so it's that type of thing that if we can encourage our admin staff to say, we don't require anything, that every patient is able to register as long as they give the correct details. We do have issues where we have a lot of patients with the same first name and second name, and then it causes confusion. But I think as long as we make it clear from our side that it's not a no if they don't have anything that confirms what their name or address or whatever is. And I think that we are all signed up to Safe Surgeries. The Safe Surgeries team do email us out every month or so. So I think that we are doing what we can, but I think it's just about sharing that message from our admin teams to say that everybody is able to register.
And I think it's that outreach work that's just so important, trying to home into these communities, which, as you said, Imran, are just not forthcoming and they don't even know what's available. And I think that's where most of this work sort of sits. Perfect. Was there anything else?
Just one more thing from me, Rima, coming back to what Imrana was saying about the Omnes cardiology. I think a common thing that's been coming up is that they're asking for 2 separate ERS referrals. So if you're referring one patient for 24-hour blood pressure monitoring and an echo, they want 2 separate referrals on ERS. Yeah. So I think that's something that I think because I think if I was referring and if I had to do a separate form for every single investigation to the same provider, I'd be looking at where else I can refer that patient.
Yeah. Okay. And I know that some 24-hour ECGs have been rejected and they're saying, no, go to do a 12 lead ECG first. And I'm like, well, I'm the clinician and I'm making the decision that the patient requires 24-hour. I know Laura's put it in the chat that LMC raised it with Jack in our joint meeting yesterday. But I will also, I will just pick that up as well and liaise directly with them. Thank you. Anything else?
Okay. Can I just, Imrana?
So sorry, there was something I did want to say. It's just about basics. Like, why is it that basics are still such a problem? Like this week it was sticky paper, like the TCAS sticky paper, and just like, I don't know, I don't know. That was just a rant. But if there's anything that we can do, kind of as a system.
It's just so frustrating, and all I can do is I'm just keep pushing. And we just had an email just before this meeting around the TQuest pathology, and I think Royal London have offered to try and give out some supply from the Royal London to Newham, but Waltham Forest are also having the same issue. They don't know why there is a delay, so they're going back because it's basically like a chain. So you can imagine we're escalating it, and then pathology escalating it to the supplier, who then supplies a TQuest paper, and it just seems to be sometimes it's just so tricky to get these things sorted out because it's just a chain of escalation that you have to go through, unfortunately. And I think Barts Health in particular they are under so much pressure. It's just enormous pressure that they're under in terms of with all the things, their waiting list and everything. And I think they just need to look at operationally how they're managing a lot of these things. But obviously, we're feeding that back and trying to work jointly with them to work through it. But yeah, I understand frustrated. There's simple things that you shouldn't run out of paper, for God's sake. But, yeah. Anyone else? Bapu?
Bapu's got his hand.
Yeah.
Thank you. Thank you. Rima, a few years ago, I was part of the working group with ELFT and Barts for paperless TQuest requests by GPs. And that's going back about 3-4 years now. So City and Hackney, and I think Barking, they have direct GP to community providers without TQuest printing, and all the patients turn up and barcodes are printed. So that exists now. So with ELFT, they have got facilities to receive that from hospital clinicians.
Yeah.
In Shrewsbury Road and other 3 sites in Vicarage Lane and all that, they have the facility. If a hospital doctor says to a patient, "I've sent the form, you book your TQuest or the Swift queue, and then you turn up, they will do the blood test. They don't need to go to the hospital to pick up the form."
I know. Yeah, this is ongoing conversations with ELFT. Yeah.
So the sticky point there at that point was the Barts Health IT team, not switching something on at ELFT side. And also another point was ELFT saying that they do not have the administrative capacity. But in fact, it will actually reduce the administrative issue if they just want to print. All they need is barcode to stick on the bottles. So, and it just takes about, I witnessed it literally, it takes about 5 seconds to print the barcode. So I think at some point, they need to re-look at that aspect. Why is City and Hackney able to do, are the GPs able to send it without printing out? Because a lot of administrative things from our side, and also waste of paper. Apart from that barcode, the rest of the form is just shredded. So a lot of green wastage as well there. So I think at some point we just need to revisit why we are delaying this process, and that will help our colleagues across Newham significantly as well. And in terms of SwiftQ, I think the phlebotomy team, they have got sufficient time. So there's Shrewsbury Road, at least I know for a fact, they're seeing significantly less number of patients for phlebotomy. They used to see something about 14,000, 15,000. I think that's come down significantly because Swift, you need to book appointments, but they do take a rare emergency blood test as well. So that's my request, Rima. So if you could, probably have a chat with Elton Bart to see where the point is. I even at one point gave my printer for them to trial it out, and it's all it works, but it's just the matter about that willpower from both these parties to support our thing as well. Thank you, Rima.
Thank you.
Okay, thanks, Bapu. Jack or Danielle, is there anything that you wanted to come in or update us with? If not, that's fine.
Just briefly, I know Tammy's on the call as well, so I don't know whether she wants to update from the NMC perspective. But from my perspective, we just to let people know that we're continuing the work with the ICB to review and try and finalize the enhanced services for at least for this year for now, and then start the conversations for next year. So we've made some progress, and Jack is on the call as well from the ICB, so he can confirm. We've got still a few issues to resolve. One of the key things that we are looking at really is it's having a clear overview of also the budget of all the services to see how these are being invested effectively. So that's really the only thing to say. I don't know if Tammy wants to add anything. Otherwise, I'll pass on to Jack.
Thanks, Daniele. Sorry, everyone. I'm at the train station, so if you hear the background noise, apologies. So I just wanted to make people aware about the Accurex and the direct debit. I think what came up in our LMC meeting yesterday was the fact that practices should just be careful about signing up with the direct debit, because obviously that's a variable amount. It's not a standing order, and so that may impact cash flow. So, and we don't quite understand the exact process about that yet. So just a little bit of mindfulness there. I think you've covered TQuest and Omnis, but I think what's really important is to make sure that we have some live examples. So if there are some issues, can you please feed back to either Jack, myself, Rima, so that we can start collating a library of cases so that we can use that as an evidence base for change. One of the things that we've also looked at is erroneous sort of diagnosis on some of the ED discharge letters. And so again, we will really be keen for some examples of how that's impacting the system. We had a bit of a concern about the data and the probity of that data being recorded. And obviously it does impact patients who can now view their own records. Just to also say a little bit of an update around Aviva, and we've all been getting the emails about the tier 3 weight management, but just to confirm, NEL has not commissioned the service. NHS haven't confirmed if Aviva even have a qualifying contract, and the right to choose team is still looking into this. So at the moment, you do not have to refer any patients, but I'd be really keen if you are getting any patient complaints to let me know so I can again escalate that to the system. And I think what I'm going to say is I'm going to leave it like that for now because it's very noisy where I am. But thank you for your time. and we'll see you at the AGM on the 17th of October, and we'll have further discussions about the collective action when Lyra will be present as well. Thanks.
Thanks, Tammy. Jack, anything that you wish to share with us?
Just sort of a note, really. So we've been made aware of the issues with the fit testing tubes, and so we've raised that with the my Cancer Alliance colleagues, who are I'm in dialogue with about a sort of, first of all, in the first instance, hopefully a communication coming out, if agreed upon with them, that referrals can be made without that result until the supply issues are resolved. Hopefully that will come out soon. As I say, I'm in sort of chats with our Cancer Alliance colleagues, and then further information about when it might be resolved. So that's sort of just a bit of work that we've picked up. And then when we have a bit more information, we will have a conversation as part of the Liz group about how we sort of how we ensure that practices aren't penalised for that as part of the Liz payment as well. So just to note that that's ongoing, we're aware of it, and hopefully in the very short future we'll just have a confirmation that those referrals can be made without the fit test result.
Great, thanks, Jack. Okay, so any other questions for Jack or LMC or Rima? Do feel free to put them into the chat bar. And we can move on to the next item on the agenda. So we've got Mohammed Ramli, who's going to be talking to us about online consultations and video consultations. And I think Mohammed is with us.
It's working. I can see it.
Oh, sorry, I'm on mute. Can you hear me now?
Yes, we can hear you now. Thanks for joining us.
All right, thank you. Thank you for having me. Thank you for having giving us the opportunity to engage. Can I use my presentation slide? I mean, or someone's going to.
So we've got Maggie that's doing your slides, but if you wish to.
All right, okay, we'll do that. Okay, yeah, that's good. So thank you for the opportunity. Thank you. I'm here today with the project clinical lead, Laura Scott, together with me. We would like to take this opportunity to engage with your team about the upcoming OCVC procurement activities. The objective of the engagement process is okay, good. Yes. We would like to share the current process where we are at now, at the whole process of procurement, why we do the procurement, and create awareness that there is a procurement activity coming up, and then there's some sort of decision making on your behalf will take place in the near future. So this engagement is to give you the heads up of what's coming in the next few months. So the progress to date, procurement activity engagement has been done so far with the practice forum, primary care team, and also GP forum like yourself. You are the first one. Next we'll be having a meeting with GP from City and Hackney, and we have similar engagement throughout the places in North East London. The second part of the engagement is with NHS procurement hubs. We are currently engaging them on the governance of the whole process of procurement, which platform of purchasing that we will go into. Just to update you, there's supposed to be a digital pathway platform being developed by NHS, but it's been delayed. So we are now contemplating and discussing with NHS procurement hubs on the actual correct suitable platform to go about this procurement activity. Next, please. So a little bit of background where we are in terms of the optics of the OCVC provider across North East London. In the beginning of the current contract, we have eConsult at 119, and a bit currently it's 116, a little bit lower than it first started. Aquaret is gaining a little bit momentum here, 102 from the beginning of the contract, now climbing up at 115. clinic start out with 23, now 27. There are 2 providers that is being decommissioned altogether from North East London, which is Emis Acton and also Engage Consult. They're no longer in the picture of the whole contract of OCVC. Ask My GP, there are 2 practices in City Hackney still using Ask My GP, and there are 7 practices across there using Dr. IQ. Next slide will show you a little bit of data of where we are at in terms of utilization. Before that, there is 2 caveats about this. The first caveat is the data does not contain any data submission from clinic, Ask My GP and Dr. IQ, because they're having slight problems, slight difficulties into sharing their data of utilization with NHSE digital team. A second caveat is this data is by key metric used nationally of rate per 1,000 registered patient, which does not saying that the practices or the places does not provide a quality healthcare to its resident. It's just saying that online consultation and video consultation wise, this is a number of submission per 1,000 patients. It does not say that you're not doing enough or you're not doing better than your peers in terms of places. It does not say that. It's just a matter of how we monitor the utilization across the ICB nationally and also places. So back to the graph that in front of you is we are currently at the second lowest from our neighbors in London region at 49.59 in terms of rate per 1,000 registered patient submission. Southwest London is quite higher up in the rate at 88.99. This is there's a question there, rate per 1,000 patient between January 2024 to June 2024. It takes like 6-month period. This is a sample of data of it. So the next slide will show you the data from May 2024 to June 2024 among the places. We can see there's a lot of comparison between places. Some places might be doing better in terms of face-to-face telephony engagement with the patients. Some places have more effort or more focused group into giving more in online consultation and video consultation. The disparity doesn't mean that places didn't do well in giving quality healthcare to the resident. Next bit on the presentation will be on this is where the engagement is all about. It's about the next step and further consideration. Currently, in terms of the procurement, we have 5 visible options that are being gathered throughout the engagement process, the discussion. The option varies. The option number 1 is we are open for practices to choose whichever online and video consultation provider that they want to. This give a lot of flexibility rooms to the practices to choose from. Option 2 is what we're having now, status quo, where we go with the 3 lot winners with flexibility. You can choose from the 3 lot winners. Option 3, instead of 3, we go back to the previous practice with 1 single provider for every practice in North East London. Option 4, we combine, still with single OCVC provider, but we combine the digital tool between online consultation and video consultation together with the SMS licenses, not fragment SMS licenses, best messaging, questionnaire, and self-booking, etc. But with single provider. Option 5, which is more, when we do the engagement activity, option 5 track a lot more feedbacks and response from the audience, which is we combine option 2 and option 4, digital pathway combination, OCVC, SMS licenses, best messaging, with multiple winners. So we have all in one pot, the digital tools, with the flexibility for practices to choose from. So there are things to consider. We have to consider which option to go for in terms of going to the procurement. Are those apps, are those options valid? How do we combine with the specification? Who's going to be on the procurement panel? What happened after procurement? Who's going to monitor the process of onboarding process, the business as usual, and so on and so forth. Sorry. Next bit, please. So coming back to the option that we have, the 5 option, in front of you is the option appraisal, where we detail out all these pros and cons of the option 1, option 2, option 3, 4, 5. What I would like to the pack, the slide pack is to review, but I would like to go into option number 5, where again the potential, the pros is we are potentially can go lower in terms of the pricing, the costing of the overall digital tools. It's economy of scale. We can do a better negotiation with the provider to lower their costing in terms of OCVC, SMS licenses, questionnaire, best messaging, and so on. But there are also consideration need to be made when we go into the next procurement activity. Next bit, please. Next is the high level and proposed timeline. So we are at the phase where we doing stakeholders engagement. We meet up with the, like I said, we meet up with the practice forum, our primary care team. We're going to meet up with PPGs and also Health Watch. Your team, GP forum is the first one. We are planning to engage more and more into to make sure everyone have the same understanding where we are at and where we're going in the future. Next bit is we're going to release. We already in the trial mode of questionnaire releasing. We're going to take 1 practices for each places, go into the trial of questionnaire. From the feedback of the questionnaire, we're going to release one set of questionnaire to all practices to be involved in, to send in your feedback. And from that feedback, we're going to consider your feedback and responses into making the decision which option to go for, what is the appetite of the new tools to be considered into the whole specification of procurement activity. We are planning to have the solid selected winners by the end of January, so that will give you an ample time to choose from. Per se, hypothetically, we choose about 3 lot winners as of now, and we're going to give you a lot of time to consider, to go in the webinars, to look and feel, to go to the engagement process with the lot winners to see what they are offering, and then make your wise, well-informed decision process into whether you want to move on into the new selected lot winners or whatever decisions you're going to make. We're going to give all the ample decision making process, all the information by the end of January till March. So from there on, we're going to be supporting you in terms of the change management process. There's a lot of onboarding process support will be given. The monitoring will be weekly, bi-weekly, fortnightly, monthly basis. There will be a team monitoring and helping you throughout the whole process. So I think this will be the last bit of my slide. So I'm gonna stop now. Is there any question or feedback?
Thanks, Mohammed.
Thank you, Aparna.
Any questions?
Mohammed, just a quick question about the rate per 1,000. Is it per day or per week, please? Thank you.
All right, sorry, I thought I've addressed that before. The rate per 1,000 that I shown in the slide was from January till June 2024. Is a accumulation of the whole 6 months from the dashboard that we got, data from the dashboard that we got. Yeah.
Thank you.
So, Mohammed, there's a comment from Dr. Anil Shah,
Yeah.
and I think he's noted down, I think, a few things that maybe a lot of the practices may be thinking, where we've educated, not just educated, we've taken real time and effort to educate the patients into using a certain tool. And now we're saying to the patients, we've pushed you and shoved you into using this system, and now we're going to think about changing it to something else.
All right. Yeah, thank you, Arpana. Thank you, Anil. So the procurement is what we call it a regulation base. The current procurement is have a what you call it the closing of the contract for 3 years. Sorry, the duration in 3 years. We are regulated to go into a new procurement activity. That's one bit, because the funding coming from NHSE. Now we are bound with that regulation. And your comment is what we're hearing. We've been hearing from all the engagement activity that we had. Minimize little less impact of changes is one of the items we are considering. We are targeting to make it less changes as possible, but we cannot preempt the outcome of the procurement. But we are trying, the project team, the primary care team, and also the procurement panel that have been set up right up now, have that the intention to make a less impact as possible. Laura, you want to come in?
Yeah, just to echo exactly what you said, we have to do this procurement because the last contract was 3 years. But exactly what Anil has said and what people are agreeing with is exactly what we're hearing from the other places as well, that obviously a lot of time and effort goes into the choices from last time. You don't particularly want to move. Some people will want to, and some people will want to explore that, and this obviously gives them the opportunity to do that. But we're very, very mindful of that. But there are certain things in terms of, for example, if a practice wants to go with a product which doesn't end up being procured, there are some things that are sort of outside of our control in terms of who will hold the contract, and the procurement hub will have to lead us on that. But that's exactly why we're sort of doing this engagement work, to get the idea from all different areas, the GPs, the practice managers, the patients, and so on and so forth, in terms of what the feel is out there at the moment. And we're hearing the same thing. So that is definitely something that's going to be very much considered with this procurement process.
Thanks, Laura.
There's a comment from Anil. I don't understand the question really.
Just Mode, in terms of from procurement, from my experience, the ICB sets its agenda for the procurement itself. So if it says as a statement that we're going to be open to any provider and goes out to tender, so yes, you're doing a consultation, but ultimately you've set that consultation up yourself with those options. So the options could have been actually, option 1, all providers, option 2, no providers, and give the money to practices to decide their own legacy, as an example. So I'm just saying that it is within the gift of the ICB to make sure that we get the right providers into the arena. But also we have to be really mindful that we went through a very painful experience with the changeover, and there is no way that we're going to be sitting down and accepting movement again. And there will be uproar, because our poor patients have gone through turmoil up and down to get us used to the provider. Our staff had endless training to now embed it. And then to say, actually, we're going to pull it very soon, when we've just actually joined up as a PCN to get the same entity. It's very discerning and very concerning to even hear that this is even up for an option. So please do take it back from us GPs on the ground and people that actually work for the service and for our patients. We cannot have new change yet again. And suddenly, for example, eConsult disappears off the platform, or Accurix or Clinic, for example, which are the real common ones that we use and we've embedded. So please do take it forward.
Thanks, Anil. Laura?
Just be reassured, Anil, no one wants that, okay? It's really not about that. We have to do the procurement process. The 3 years is up. So it's not about that. And it is very much, because like you say, obviously from some people in the ICB, the ideal would be, let's just all go with one and this, that, and the other, and we combine. But we're very, very aware that practices are different. They want their choice in it. So every single aspect is being looked at and studied in terms of how it can be supported. We just don't know the full outcome of that yet, and we have to go through this engagement procurement process. We can't just presume on behalf of patients and practices. We have to go through this. So that's part of the process. But another thing that we haven't said as well is, the actual procurement panel hasn't been decided yet. Anyone who wants to get involved with that, please get in touch with Mo. You know, obviously I'd advise that it's managers or staff in the practice who use the models very much on the back end, but also clinicians who use it very much in the triage process and can pick out pros and cons to it and stuff as well. But like you say, there are some main providers, and people generally are saying that they would like to see those ones in the next contract.
Yeah, and Laura, just to add, especially because 2 years ago, as you know, I was hounding you that we should have one provider for now, one provider for all practices, so we're all the same, so we're all integrated, and that wasn't up for grabs. And now suddenly the ICB wants us to have one provider. You can't just stop and change like this because it really affects us on the ground. So,
but
yeah.
but I mean, in many ways, one provider works, but actually, for a lot of practices, it doesn't. You've got questionnaire based with all your questions, which some practices love, that triage process, and you've got the very, very simple ones, which some other practices really love. And so it's not quite as simple as that, even though in some ways it would be. But actually, what we probably see is the practices who really like one model probably wouldn't use the other one effectively. So that's something to consider, because you do really have the polarizing ways that people use it.
No, definitely. And that's why I think when we first went into online consults a few years ago, that was the opportunity to have one provider. And we did stress that as a system, we are all EMIS in Newham. It'll be really useful to have one provider. And that wasn't up for grabs at the time. And there was a lot of argument saying, no, we can't because of procurement. We can't just dictate and put one provider on the ground. So now to suddenly change that when we actually don't want you to have that as being an option is just a bit ironic.
But it's not changing it. It's not changing it. It's engaging with everyone to find out what they want. And like I say, you know, if everyone wants to go with one provider, they can do that.
Now it's too late because we see your graph even, there's endless different options. So that's not even up for grabs now.
So I think that what I would suggest is that when Mohammed shares out the details of this process, that if all practices, you know, discuss it within your practices and then share your thoughts before the process ends. Is that all right with everybody? Yeah.
So that would be great. Thank you.
I'm just mindful of the time, and as usual, I'm running behind. So I'm going to move on to the next item on the agenda.
Thank you, everyone.
Thanks all.
Thanks, Mohammed. So we've got Dr. Devon Patel, who's an elderly care consultant at Newham. He's going to be talking to us about primary care referrals into the frailty virtual ward. And just to make clear to everybody, he also has another role, and that is as my better half. So he is my husband as well. So just to declare that here. Devon, have you joined?
I have joined. Can everyone hear me?
Yes, we can hear you. All right, thanks.
Perfect. So thank you for having me present the talk on Newham Hospital or Barts Health Initiative, the frailty virtual wards, which we've started rolling out since towards the back end of last year. So if I think Maggie's got the slides up, perfect. Next slide, please, Maggie. So I just want to basically touch base on what virtual wards are, what we provide, and how we want to try and expand it out to the primary care teams going forward. So essentially, virtual wards, it's a huge drive at the moment from NHS England to try and move a lot of this acuity that we're seeing in hospitals out back into the community, to allow patients of all ages, not just frailty, to basically receive hospital level care, but in the comfort of their own home. So there are a number of virtual frailty wards, virtual wards that set up in respiratory, cardiology, but frailty is one of the big ones that NHS England want to try and deliver. So the long-term plan from NHS England is that they want to have 40 to 50 beds of virtual wards per 100,000 population. So in Newham, that's around, I think Newham's population is around 350,000. So that equates to around about 9 or 10 wards. So why are virtual wards important? So it's basically 4 main reasons. To reduce the burden and pressure on the acute hospitals, by moving some of that acuity in terms of early supportive discharges out into the community, where that they can continue receiving ongoing monitoring and ongoing hospital level care. Improving patient outcomes. I think we all know that patients always do a little bit better in their own homes and their home environments, where they're surrounded by families, their own day-to-day living, and that's actually good for their mental health rather than being stuck in hospital for days and days on end. There's also driving in terms of cost efficiency, so some of that inpatient burden is reduced, and staffing levels is also reduced. And then there's the terms of integrated care, so collaboration between communities, other hospitals, primary care services. Next slide, please, Maggie. So frailty in Newham. So Newham, as you all know, is not an elderly borough. It's probably one of the youngest boroughs in London, but that means over time everyone will get a lot older. So I've got 2 slides here. One shows sort of the tracking population increase over this is the predicted age of Newham over 50, and on the right I've got the social deprivation scale. So we all know that social health economics and our borough being extremely challenging and diverse in terms of access to healthcare, trust with healthcare, and them being more deprived leads to lots of health inequities across the entire borough, which would lead people being more unwell, having extremely as in more comorbidities, coupled with them getting older. That means that in the future we will have an extremely frail population going forward, and that's why the idea to highlight these patients early to prevent hospital admissions, optimize anti-frailty components that we can see. That's the ideal long-term goal in Newham. Next slide, please. So this is our current model. So we have effectively 2 arms of our service. One is the early supportive discharge, and one is the admissions avoidance. So we started in August last year. It was mostly early supportive discharge. So we see patients that come in who've got like mild AKIs, and we sort of tweak some of their medications, give them a little bit of hydration. We feel that they don't need to stay in hospital for 3 or 4 days to completely normalize their renal function. Then we can get them home and follow them up in the community in a few days' time. Also, things that we see is like pneumonias. We manage heart failures as well. And that's more from the back end of the hospital. We're also trying to develop the front end of the hospital in terms of admissions avoidance. So we have patients that are referred in directly from ED. They're sort of mostly fallers, but otherwise have got fairly decent setup, so we can go in, do falls optimization, meds recs, and things like that. We get referrals from outpatient clinics, mostly from the care of the elderly clinics, patients that aren't able to travel to hospital. We get referrals from the vigilance response units, who feel that patients could probably remain at home with just a little bit more monitoring from the team, and we also get referrals from other hospitals and Barts. We get from BHRUT, which is our neighbouring trust, and I think we've had 1 or 2 from the Homerton as well. So when somebody is admitted onto the virtual ward, we receive a referral, and then we will designate an MDT when to see this patient. So our service in Newham is a consultant-led geriatrician service. So me and my colleague, Dr. Aberdeen, intertwine every other month. We have an MDT every single day, Monday to Friday, at 2:30, where we will go through extensively every single patient, discuss every patient, decide what is the next step in terms of the management. Do we need to change any medications? When do we need to go and visit them? What do we need to actually have a therapy review? And then from that point of view, once we're ready to discharge, then we tie in with community services. On our MDT, we have our community GP, who's Pfizer, Dr. Khan, who sits on there, and she's able to access EMIS and writes any notes that necessary and pulls any information across necessary. We also have the community team, so we have a representative from ELFT, which is usually one of the community district nurses, and they're able to liaise with their teams in terms of have TVN seen them, or if they're ongoing with wound care, or whether podiatry, community phlebs, etc. have also seen them. And then when we discharge, as normal, we'll send a discharge summary highlighting their ongoing patient care. I think one thing that we're trying to tidy up at the moment is if a patient is discharged from hospital, you'll receive a discharge summary, and then when they're discharged from virtual ward, you'll probably receive another discharge summary pretty much in quick succession, as patients tend to stay on virtual ward for about 2 weeks. Next slide, please, Maggie. So this is the team. We're not a huge team, but this is the makeup of the team. So we have, as I said, 2 geriatricians. So me and Dr. Aberdeen spend 1 month on the ward, or on the virtual ward. And we oversee the day-to-day functioning in terms of the ongoing patient's care. We have Mubashira, who's our pharmacist, so she's able to liaise with all the pharmacies, prescribe any drugs, change any medication. She's able to do meds review. We have Des, who's our Band 8A nurse, who oversees sort of the clinical function in terms of the nurses. And we have 2 Band 6 nurses who go out and do visits. Then we have Joanna Daniel, who are our physiotherapists and occupational therapists. So they'll go out and do pulse reviews, order any equipment that's necessary to optimize patients at home. We have Pfizer, who I've already said is our GP, and then we have Samaya, who's our admin person. Next slide, please. So the way we do referrals, so we accept referrals all the time, but we vet the referrals during our MDT. It's usually at the end. So they're screened Monday to Friday. We have a fairly strict inclusion criteria. So obviously, the patient has to have a Newham GP and address, because that's the way the service is managed. And the patient has to be amenable to having effectively a home visit. Patients over 65, and we tend to use the Rockwood Clinical Frailty Scale. I've just put a picture at the top. If nobody's aware, I can always share that out. And the things that, as I said, things that we're seeing is like mild AKIs, we do meds rec, constipation, anything that's sort of improving, we tend to go and see, and sort of an identified goal at the end of it. We also have therapies only referrals. They have a very strict set of criterias. So everything sort of needs to be done within that 2 weeks, or there and thereabouts. And then we have some exclusion criteria. So patients that are unsafe at home, we don't tend to accept, because they probably shouldn't really be at home if they're unsafe. Anybody out of borough, and anyone sort of requiring active dying input or palliative care input. Next slide. So we do so we receive our email, our referrals through email. So there is an email, there is a referral form that needs to be filled in and sent to Barts Health at NHS Frailty Virtual Ward. I say we screen it, and then we either accept them or reject them, and we highlight if it is a rejection, then we highlight why that's rejected and refer them to or we suggest a referral to appropriate service. That's my email if anyone has any further questions. What we would like to do is, I understand that the PCN network is 9 PCNs, and what we would like to do initially is to introduce the service into PCN by PCN, and we would like to start in sort of Newham North, which I believe is Rahana's PCN. She's sort of the lead for frailty in the borough from primary care. So we think it's probably a reasonable start there. So if there's any issues, then we can smooth them out before opening them up throughout the other PCNs. I guess that's just to sort of highlight the tour. There's probably more questions than I've sort of given information for us, but I'm happy to take any questions right now if anyone has any.
Rima?
Thank you, and thanks for that overview. It's really helpful. I think initially when this was being set up, there was some kind of nervousness about how much work would be coming to sort of primary care in terms of once the patient is in the community, it's very easy to kind of default back to the GP. But I just want to say, looking at some of the outcomes of the virtual ward and how it's been set up, I think it's really good. I think patients have really benefited from it. There've been a very, very few occasions where I think some of our patients have been lost to any kind of follow-up out, but that's been really, really rare. And when I've escalated it, it seems to be sorted like straight away. So I just wanted to say well done on the service. I think it's really benefiting our patients. So yeah, well done. Thanks.
Thanks.
Any other questions for Dr. Devon? No? Okay, good.
I think there was one that came up in the chat.
Oh, so Humaira's written, you know, Humaira, there was a slide that Devon shared that's got the inclusion exclusion criteria. So when we share the slides out, you'll get that information. Devon, can I ask you share a copy of the referral form that you mentioned as well,
yep,
so that GPs can see that? But obviously, I think from what I understood, we're not able to refer to that to your service just yet.
No, it'll only be Newham North, but I think Rahana's off this week. So I think we're meeting with Rahana next week, so we can discuss when we can start that PCN.
Okay, so maybe not share the form, because I'm sure that all of us will start referring in without waiting for our date. There's a question from Sheetal. She's asking, can the rapid response team or district nurses refer in, or does it have to be a GP surgery or a GP referral?
In terms of yeah, so we've had rapid response refer to us already, and we've had breach responses. I think the difficulty at the moment is we don't have a full-time community geriatrician, so we don't always have somebody as a doctor that goes out and sees the patient, but our nurses are good. I do go out from time to time, even though it's not in my job plan, but that's just if somebody hasn't seen it. So say like if an ED/SHO has seen a patient, I will try and go out and see that patient so that person's had a full geriatric overview. For example, this morning I was out, there's a patient who we couldn't get into clinic, so we coordinated with his daughter. Son lives 100 miles away, so we coordinated. So we went out to see him. We did a full CGA. He's a little bit dry. He's going to the toilet too often at night time, so we're going to reduce his furosemide. He's taking hefty doses, 80 BD, so we're going to reduce it to 80 OD. Mubashir is going to liaise with. So we've already taken the tablets out the Dosset box, but next week when we review them, if we feel that the 80 is fine, she'll go to the pharmacy and sort everything out with the pharmacy and reissue the Dosset boxes. So it's the sort of things that we will try and do. But yeah, so we do receive referrals for each. We've never received any referrals directly from the district nurses.
But are you happy to take those?
Yeah. Okay.
And then Dr. Anil Shah's asking, can you give fluids at home to IV?
Not at the moment, because we don't have the skill or capabilities to do that. But I would imagine if the service continues ongoing, then that would be something that would happen eventually.
Okay, and then just one last question from Imrana in regards to timeline. So do we know what date or when you're likely to start this rollout, so to Rahana's PCN?
So obviously when we meet with Rahana next week, I mean, we're ready to receive referrals almost immediately, but it'll probably be the week after. I think we've kind of delayed it because we've just had one of our transformation leads has moved, so they're also in a state of flux. So that's why it's just been a little bit later than we had anticipated. But we could once I've spoken with Rahana, it will probably be in a couple of weeks, most likely.
Okay, great. Okay, thank you, Devon, for joining us. And if anybody
Okay,
has
thank
any
you very much for having
questions,
me.
please email them out to Devon, or you can pass them to me and I'll pass them on. Okay, take care. See you later, Devon. Thanks. Okay, so the next item on our agenda, and apologies to colleagues because as usual I'm running behind. We've got Kumbi who's going to be talking to us about breast screening in Newham. She's going to be giving us some updates on how we can improve our uptake as well. So Kumbi, over to you.
Perfect, thank you. Good afternoon, everyone. My name is Kumbi. I'm the Health Promotion Lead, presenting on behalf of North London and Central and East London. I'm joined today by my colleague Claire Mabena, who I'll let introduce herself.
Hi, good afternoon, everyone. I'm Claire Mabena. I'm the lead clinical nurse specialist for the breast screening service supporting Cumbie.
Perfect, thank you, Claire. So I'm going to go over some service updates and then a little bit about how we can work together to hopefully increase uptake across NEL. Next slide, please. So just a refresher, I'm sure you're all aware of some of the breast screening statistics. Breast cancer remains a significant health issue, with 1 in 7 women in the UK expected to be diagnosed in their lifetime. Sadly, it does cause around 11,500 deaths annually. However, we do know that screening plays a crucial role in early detection. In 2020 to 2021, just under 11,000 cancers were detected through breast screening. London has unfortunately seen the lowest uptake rates in the country, with only 50.4% of women attending during screening during 2021 to 2022. Largely due to the pandemic, the national target is 70%, and we are working hard to increase this uptake. Importantly, screening saves approximately 1,300 lives every year by detecting cancers early. Next slide, please. So there are 2 services that someone can move through to get a breast cancer diagnosis. Oh, just back one, please, Maggie. Thank you. Oh, no. Oh, no. Back to the 3rd slide, if possible, please.
Sorry, bear with me.
No, it's all right.
What on earth? Where's it gone?
Go bring, reduce the slide. And
No.
then put that back.
Do you want
How
me
can I
to?
go back?
Shall I put it up, Maggie?
Just-
I'll put it up
just-
for you.
Exit out.
Is that the one you wanted, Kumbi?
Yes, please. Thank you.
That's right. That's right.
Don't
Okay.
worry,
Oh,
Maggie.
she put it on.
Thank you.
Okay, perfect. So, okay. Ready to go? Okay, perfect. Thank you.
Yeah, go for it.
Perfect, thank you. So there are 2 services that someone can move through to get a breast cancer diagnosis. So first of all, we have the symptomatic service. So this is where a patient notices a change to their breast and reports it to their GP. And then their GP refers them through to a breast specialist. And that's the symptomatic pathway. Now, running parallel to that, we have the screening pathway. The screening pathway is for well women aged 50 to 71. The breast screening program will automatically invite them every 3 years. And the goal of the screening pathway is to detect cancer early, even when there are no symptoms, improving the chances of successful treatment. The breast screening program invites women aged 50 to 71 every 3 years. The first invitation usually arrives before their 53rd birthday, sorry. Women over 71 can self-refer by contacting the breast screening hub for an appointment every 3 years. We've noticed in a lot of our community engagement work this year that women over the age of 71 are unaware that they can self-refer, so haven't been going after that. So please do highlight this within your practices. They are more than welcome to keep coming to get screened up until they're 100 plus. For women at risk of for women at a higher risk of developing breast cancer, such as those with a family history, the high-risk screening program offers more frequent screening and additional tests like MRI scans. GPs play a key role by referring these patients to specialists for further assessment. There's also the NHS Jewish BRCA testing program, which offers saliva-based testing for women with Jewish ancestry to identify BRCA mutations, providing tailored risk assessment, risk management. Next slide, please. All breast screening appointments across London are managed by our centralised administration hub. Patients can easily change appointments or find out when they are due for screening through this service. Since 2021, invitations have been managed based on the NTDD system, which has helped streamline the process and reduce duplicate invites. Next slide, please. So this is an overview of our health promotion projects that are underway to increase screening uptake, particularly among communities with historically lower engagement. This includes work with people with learning disabilities, ethnic minorities, and those experiencing homelessness or severe mental illness. For example, targeted interventions for women with learning disabilities and community outreach efforts with Somali, Bangladeshi, Romanian, Turkish communities are key aspects of our strategy. Next slide, please. So this slide just gives an overview of our current process of how we calculate uptake percentage. Clients receive an appointment time and the appointment remains open for 6 months, during which they have the opportunity to attend. If they do attend, they return to the 3-year screening programme. If they DNA or do not attend, they can still book within the 6 months, receiving further invites, text messages and reminders from the service. We assess performance by comparing the number of clients who attend within the 6-month window to the total number invited. While non-attendance doesn't affect GP uptake, encouraging clients to attend can foster long-term engagement with the screening service. Feedback from clients shows that they are more likely to attend appointments after engaging with their GPs or seeing promotional materials in their practices versus speaking to a stranger on the phone, for example. Next slide, please. So we just wanted to include some examples. So these are 4 practices that we have pulled across Newham. So as you can see, performance has increased across all these practices, which is fantastic. We've also noticed a decrease in DNA numbers. Generally, the variation in patient volumes across the year can affect statistics. As a result, we do predict that performance in 24-25 will continue to increase. Next slide, please. So we're continuing working on DNAs with providing practices with reports and templates for text message reminders. Each practice can receive a weekly report listing patients who have missed their appointment. We strongly encourage GPs to contact these patients and remind them to rebook their screenings. Engaging with these clients has proven to increase attendance rates. We can also provide one-off DNA reports upon request. Next slide, please. So women with learning disabilities are less likely to attend breast screening appointments, but the health promotion team is working closely with GP practices to increase uptake in this group. We encourage practices to share their eligible patients' details so we can arrange appointments with reasonable adjustments and just make it clear that we can offer pre-visits, carer visits, anything that will make the screening appointment easier. Easy reading materials are also available to support patients during annual health checks, ensuring that they have information needed to engage with the screening process. Next slide, please. So GP packs are available and contain comprehensive information about our programme, including resources that can be shared with patients in waiting areas. These packs will be provided 6 weeks before large groups of patients are due to be invited, helping you to stay informed and prepared. Next slide, please. So lastly, our health promotion team is here to support you with DNA reports, pilot programs and any targeted intervention efforts. We can assist at health and wellbeing events, any community engagement events. Of course, it's currently Breast Cancer Awareness Month, and we can provide promotional content for your practices, websites or newsletters. If you do need any resource or support with reasonable adjustments for clients with learning disabilities, please do contact us. We're also happy to assist any clients who have a physical disability or if they're experiencing homelessness. We now have a mobile number, so do take note of that, which we can be contacted on. And that's my last slide. Thank you. Any questions?
Thanks, Kumbi, for that. Now, there's one comment that from Dr. Shah, but he's actually said what I had on my, I'd written down what I needed to ask about. So when we get the letters after patients have been screened, or sometimes where they haven't, we get we might get in an envelope, we'll get about 10 pages. The first page will have a date and a letterhead at the top, and then half of the A4 page will have one patient. The bottom half will have a different patient. And I've tried to, I emailed somebody about this about 4 or 5 years before COVID, but nothing came of it. We have to cut the paper in half. We scan it manually. I think the way that the results are shared and even the DNAs are shared is not a practical one. So I'm happy to speak to you outside of the meeting to explain, because I think you're not, unless you see what we get, you're not, you may not necessarily know.
I do Well, actually, I see the reports electronically. I don't see them once they've been printed out.
Yeah,
so I didn't know the format in which they've been
help
sent
you.
out. So yeah, happy to catch up offline or outside this meeting. I might pull Claire in just to help answer in a better way, because she's more experienced than I am. Claire?
Hi. So
Hi,
yes,
Claire.
this is a historic problem, and every meeting I go on, I get similar feedback. We have got a pilot program which is running at the moment, looking at making these more electronic and more user friendly. The issue we have is obviously the breast screening program was the first program to go live back in 1988. Our IT systems are really clunky. They don't really support and with sending stuff electronically, but this is being highlighted as a national issue, not just a local issue for you. So as a result of this, they are looking at how we can make these reports more streamlined and more electronic. Unfortunately, with breast screening, where other IT technologies advanced during COVID, ours really didn't. But that is something we're looking into. But unfortunately, at the moment, that's the best tool we have, which is why Cumby and I, with any of you GPs on here, we're happy to run you those Excel DNA reports, which will help you with your coding and send them through to you. But unfortunately, we can't change the current system until we monitor the success of this pilot that they're trying in the background at the moment.
Okay, so Claire, with regards to the Excel spreadsheets, are these already being sent out to practices, or do we need to request?
No, this is a piece of work me and my team are doing. So
Okay.
when we're coming on these meetings, we will do a report where we'll run off your DNA lists and send them through to you. So anyone who wants us to do this, to update their systems, our contact details were in the last slide. Please just contact us with your surgery details and we'll run that report, and just let us know the time frame you want. Do you want 6 months? Do you want 12 months? Do you want longer? And we can run that and send that through to you as a one-off. But we can't change the current system that the hub use with sending these reports to you. We know it's, it's not a good way of doing things, having multiple patients' information or clients' information on the same sheet. It's not very helpful, but I am really hoping the pilot will be successful and there will be a change soon.
Okay, and then just one other question that I had. I remember historically, practices used to get sent lists of patients that you were hoping to invite in the next quarter. So the quarter before, we would get a list of all the women that were going to be called in the next quarter for their breast screening. So we could sort of practices could give patients a heads up to say that you're going to be getting your invite for breast screening, please do go. We don't get those lists anymore. So I don't know if there's any way to look at that as well.
We can take that back to the hub and ask why they've stopped sending out these lists, and is there any way that that can be reactivated. So that's an action Cumby and I can take, and once we've spoken to the hub, we can feed back to you with regard to that. Okay,
good. Now, there's two other questions that I'm going to ask. If it's all right, could you just take a look? It's the last two comments in the chat bar, or now there's three. So are you happy to just answer them in the chat bar so then I can move on to the next item on the agenda? Yeah,
definitely. Perfect. Thank you.
So thank you both for joining us, and please do look at I think the biggest thing for the practices is the way that the results are sent out. So it's good to hear that you are aware of that and looking to do something to rectify it. Okay, so the next item on the agenda is Marie Ryder, who's going to be talking about NHS apprenticeships. So Marie, thanks for holding on, and apologies that I've run us behind today.
No, that's fine. It was interesting, actually. My mum was diagnosed with breast cancer when she was 89 and successfully has had a mastectomy, and she's all singing or dancing now. So that she's an older person that experienced this. So I wanted just to introduce myself. I'm Marie Ryder. I'm Head of Apprenticeship of Delivery at Community Matters. You'd normally be seeing my colleague Max Stoner, who is Head of Apprenticeship Development, but unfortunately he's not available today, so you've got me. It's just a really quick overview regarding what Community Matters does, what apprenticeships are, and which ones you may be interested in. So perhaps I could have the next slide. Thank you. So what do we do? Well, I think we started about 14 years ago. I think it was in 2010. I wasn't there with Community Matters then, but really being a sort of management consultant, really, working a lot with workforce development and working with the NHS community hubs across London. We're a London-based organisation. We're based in Wood Green, and so the start of Community Matters was really all about being a management consultant and offering solutions. We've always kind of focused on health and social care, although we do run apprenticeships that may be thought to be outside of health and social care, but we contextualise them to health and social care if that's what people want. We offer bespoke things. We've managed over 500 programmes and projects for the NHS. And delivered over 1,000 training sessions. So, for example, one of the sessions that's going on at the moment is training for people in the NHS, managers in the NHS, about the menopause, for example. So they understand the experiences of employees that they might have with menopause. So a lot of what we do is about training needs mapping, looking at what people need in terms of workforce development and how we can try and close that gap through apprenticeships is one way of doing it. Could I have next slide, please? Thank you so much. This is just a quick snapshot of who we support. So quite a broad range of people. These are the NHS people that we support, but we also support charities, local boroughs, community hubs, lots of things. So what are apprenticeships? Now, I don't want to bore you to death about apprenticeships. I could, but apprenticeships, I think, is an umbrella term for work and training at the same time. And it includes the specific apprenticeship that somebody's doing, but it also includes things like maths and English tuition. In some cases, it might be the care certificate, whatever is involved in the requirement of the apprenticeship. So I can't really see. Can you make that any bigger? Because I can't really see it. It's available to. So I'm peering here. Available to individuals aged 16 to 100. Now we don't have anyone that's over 100. We do have people in their 60s doing apprenticeships. Perhaps they're looking at a new career that they might want to move into. We don't have anyone of 16 at the moment because, again, if they're working in health, they tend to be a little bit older. And we do have somebody of 17 who's doing a business admin, so forth. So they can be used with new or existing employees. So you see quite a pattern, differences in the pattern of how apprentices come to be on the program. So sometimes they recruit directly and then they go on the program. Some of them are people who've been employed for some time and they're upskilling their workforce. Apprenticeships are funded by the government through the ESFA, which is the Department of Education, effectively, and they're funded by the levy, which is a sort of pool of money that's put together by organisations, larger organisations, organisations with larger payrolls. They are available at all levels. We tend to offer level 2, level 3, and level 5 are the main levels. Level 5 is equivalent to first year of university. Level 3 is sort of GCSE level. So there are apprenticeships that go up to master's level. There's over 800 apprenticeships, and they're building, new ones all the time. The main thing is that the apprentices are learning as they work. So, that kind of practice theory gap that we used to see in particularly professional education, that it really does try and close that gap to make sure that they are able to apply knowledge, skills and behaviours that they've learned through the apprenticeship within their workplace and vice versa as well. So it's very much about learning as they go, and they are expected to have 20% of their working hours dedicated to the apprenticeship. And we call that off the job hours, and it's about 20% of their working hours. We know that in education theory, learning by doing is one of the most effective ways of learning. And a lot of our learners, that is definitely how they learn best, learn by doing. And so apprenticeships really take advantage of that. The reviews that have been done on the effectiveness of apprenticeships suggest that about 65% of apprenticeships will progress into management roles. And I think it's important that learners understand that they're not going to do that apprenticeship and never do anything else. You know, the whole ethos of lifelong learning is completely embodied within the apprenticeship, right from day one and so forth. And the evidence suggests that 77% of employers say that the apprenticeships make them more productive. So there's some evidence there to support the use of apprenticeships as a vehicle for upskilling your workforce and growing your workforce. Could I have the next slide, please? So why apprenticeships? Well, I think I'd say because for the learners, there's no cost attached to it. I think for the employers, it is an answer to some of the issues that currently exist, particularly within very large organisations like the NHS. And looking at the long-term workforce plan, we can see that there's 112,000 NHS vacancies throughout the NHS. There is reliance on temporary staff. Often temporary staff are more expensive, particularly for agency staff. There's an estimated workforce gap which will go up to about maximum 360,000 by 2036. So, you know, within the NHS, the long-term plan would suggest that apprenticeships could offer one way of upskilling your workforce to train and grow the workforce. To retain the workforce, that's a big issue, isn't it? In some careers, particularly in the care sector, there's a huge amount of churn in the amount of staff going into it, and that we embed that culture and improve retention, and that we reform things by working and training differently. Next slide, please. So these are other targets that are within the workforce. I find these quite interesting, all these double the number of training places and number of GP training places, medical degree apprenticeships, and so forth, and adult nurse training and places. I used to be a midwifery lecturer in my previous life, and I know how difficult it is to easy it is to say, oh, let's just double the workforce, but how difficult it is to ensure the safety of that training within the clinical setting through supervision and mentoring. But there is a thought to increase apprenticeships and other alternative routes. There's increasing number of alternative routes now, and a relaxation of the apprenticeship funding rules, which allow a broader range of people to be able to do apprenticeships. They want 22% of all training for clinical staff to be delivered through apprenticeships. So, and again, with dentistry, expanding training places. So there's big targets there, and apprenticeship can play its part within it. So how successful are apprenticeships? And I think this has been a question that's been asked really for quite some time. The statistics would suggest that 113,000 apprentices have started within the NHS in the last five years, and that increase is now 135%, so it's really increased a lot. Nice to see retention after 5 years at 75%. I think that's fantastic, and an increase in those retention rates as well. And with 60% moving into more senior roles within 3 years. So they're getting the foundation training, and then they're developing and growing their careers. And about 30% come from a global majority backgrounds. And that's great to see, because we need to be representing the diversity in the population in terms of who's caring for our clients. So these are just 4 of the apprenticeships we offer at the moment. The business administration, which is level 3, the business administration tends to have an NHS bent to it. So although it's about being able to manage information files and so forth, we do have an NHS bent in it. So a lot of people can do that course. Practice managers, receptionists, program project managers. We've actually got quite a lot of receptionists on it at the moment. Community health and wellbeing is a fairly new apprenticeship. We've just started our 2nd cohort on Wednesday, and for these are people who are working within a community, charity, or NHS organisations. And within quite a range of job titles, such as social prescribers, community champions, health coaches, care navigators, all those sorts of things. And it really is a way of filling unfilled positions such as social prescribers, reducing non-essential primary care visits, and addressing the 5,000 shortfall in public health specialists. So public health is a big part of that community wellbeing apprenticeship. The other apprenticeship we offer is the lead adult care worker, which is at level 3. And again, we've got lots and lots of people who are working in the care sector within domiciliary or care settings. And this is where there's a great need for training. There's 165,000 vacancies in care, and we've got an ageing population, as we know, and it's felt that the apprenticeships reduces the annual churn of losing people within the care sector. A lot of people start a job in the care sector, not sure about it after a while, and then they leave. So this is thought to be one way that we reduce the churn for that. And as a team lead, it's actually team leader, supervisor, level 3. And again, we don't run this at the moment, but we've got people that are interested in it, and we're looking at setting it up for the new year. So we've got people in who have perhaps looking to move on in management, have a small team that they manage, and it helps to prepare them for managing, coaching, mentoring, that sort of thing. And 60% of NHS staff report that there are not enough supervisors or team leaders. And there's thought to be a 20% improvement in performance and 15% reduction in staff turnover with apprentice trained managers. It's really, really important that our managers are effectively trained and that they can coach and that we can improve the management in this country. Next slide, I think that might be it. Yes, so next steps. Well, I'm going to direct you to my colleague, Matt Stoner, at communitymatters.co.uk. He has also produced an apprenticeship inquiry form. So there's a link there to that. If anybody would like to fill one of those in, then it goes to him first, and then we discuss the inquiry and decide on the best way forward. Usually we have a Teams meeting initially. So thank you so much for listening to me. Any questions? I'm quite happy to answer any questions.
Thank you, Marie. Any questions for Marie? No, I think what you shared was quite comprehensive, so there was no need for any questions, but we'll share the details out that you've given us so that colleagues will have that link to apply for the programme.
Yeah, or they just get more information and so forth.
Okay, great. Thank you, Marie.
Thank you. Thank you. I'll leave the meeting now. Is that all right?
Yeah, that's fine. Thank you. Have a good weekend.
And you and everybody. Bye.
Thanks. Bye. Okay, so sorry, we've overrun a bit, but thanks to everybody for staying. I can see that the majority of colleagues have stayed on the meeting. Anything that anybody else wants to raise or any questions or anything like that? Nope. Okay. So I look forward to seeing hopefully many of you next Thursday at the AGM. Please do join us. It will be a great opportunity just to meet outside and meet face to face you know, outside a Teams meeting. So please do come. Let Maggie know if you're coming, because I won't be sharing any of my desserts with anybody. And thanks everybody for staying on. Have a good weekend and hopefully see you next week. Okay, take care. Bye.
Everyone, thanks, Aparna.
Thank you, Aparna. Bye.
Thanks. Bye.